That tingling, burning, or numbness moving through your legs and feet isn't just uncomfortable. It is your nervous system sending a distress signal that most doctors misread as inevitable aging. The 2026 food pyramid points to a specific cluster of nutritional deficiencies behind it, and the fix is already in your grocery store. This video is educational and based on current nutritional research and the 2026 Dietary Guidelines for Americans. Peripheral neuropathy has multiple causes, some of which require medical evaluation and treatment. Do not self-diagnose or discontinue any medication without consulting your healthcare provider. Do you deal with tingling, burning, or numbness in your feet or legs? Tell us in the comments how long it has been going on and whether you have been given a clear explanation. Share this video with someone who has been living with this. There may be a nutritional answer they have never been offered. Peripheral neuropathy is the medical term for nerve damage or dysfunction in the extremities, primarily the feet and lower legs. It affects an estimated 20 million Americans, with the large majority of cases occurring in adults over 60. Its hallmark symptoms are familiar to anyone who has experienced them: tingling, burning, pins and needles, sudden sharp pain, or progressive numbness that begins in the feet and gradually works upward. In severe cases, it progresses to weakness of the lower legs, loss of balance, and a dramatically elevated risk of falls and fractures. The consequences of falls in adults over 65, hip fractures, head injuries, extended hospitalizations, loss of independence, are among the most serious medical events in this age group. Neuropathy is frequently a contributing factor that receives far less attention than it deserves. The standard medical explanation focuses on diabetes as the primary cause, and while diabetic neuropathy is real and significant, it accounts for only a fraction of peripheral neuropathy cases in older adults. Alcohol-related neuropathy is another recognized cause, but a substantial proportion of cases, frequently undiagnosed or misattributed to age or early diabetes, are nutritional in origin, driven by deficiencies that are both preventable and partially reversible with the right dietary changes. The 2026 Dietary Guidelines address this directly through their emphasis on nutrient-dense animal foods and the rehabilitation of the full range of B vitamins in the older adult diet. The B vitamin complex is the most critical nutritional factor in peripheral nerve health, and it operates through three distinct mechanisms. Vitamin B1, thiamine, is essential for the energy metabolism of nerve cells. Nerve tissue is metabolically expensive. It consumes disproportionate amounts of glucose relative to its mass, and the enzymatic machinery that processes this glucose depends on thiamine as a cofactor. Thiamine deficiency, even marginal deficiency below the level that produces clinical beriberi, impairs nerve energy metabolism and contributes to the axonal degeneration that produces tingling and loss of sensation. Alcoholics have long been known to develop severe thiamine deficiency neuropathy, but older adults on processed food diets, which are largely devoid of thiamine-rich whole grains, legumes, and pork, can develop subclinical thiamine insufficiency without ever approaching a diagnosable deficiency state. Vitamin B6, pyridoxine, is required for neurotransmitter synthesis and for the maintenance of myelin, the fatty insulating sheath that wraps around nerve fibers and enables fast, accurate signal transmission along the nerve axon. Demyelination, the degradation of this sheath, is one of the primary mechanisms by which peripheral neuropathy produces its characteristic symptoms. When myelin is intact, nerve signals travel at speeds up to 70 meters per second. When it is degraded, signals slow, misfire, and produce the confused sensory experience of tingling and burning. B6 is found in chicken, turkey, salmon, potatoes, and bananas, all foods that were present in traditional diets, and that have been partially displaced in the modern, older adult diet by processed convenience foods with low B6 content. Vitamin B12 is perhaps the most important of all for peripheral nerve health, and its deficiency is alarmingly common in adults over 65. B12 is directly involved in myelin synthesis through its role in the methylation cycle, the biochemical pathway that produces the methyl groups required for myelin maintenance and neuronal DNA repair. B12 deficiency produces a characteristic pattern of nerve damage that begins in the longest nerve fibers, those running to the feet, and progresses upward. This is precisely the anatomical pattern of the most common presentation of peripheral neuropathy in older adults, symptoms starting in the feet and moving up the legs. The fact that this pattern so closely matches B12 deficiency neuropathy is not coincidental, and it is significantly under-recognized in standard clinical practice. The absorption problem makes B12 deficiency particularly insidious in older adults. B12 requires a protein called intrinsic factor, produced by the parietal cells of the stomach lining, for absorption. As gastric acid production declines with age, partly through natural atrophy and partly through medication use, parietal cell function diminishes and intrinsic factor production drops. Adults taking proton pump inhibitors or H2 receptor blockers, among the most commonly prescribed drugs in the over 60 population, have substantially impaired B12 absorption, even when they consume adequate amounts in food. The dietary fix for this specific problem requires either high-dose oral B12 in the methylcobalamin form, which can be absorbed by passive diffusion at very high doses, bypassing the intrinsic factor pathway, or B12 in the sublingual form, which avoids the gastrointestinal absorption problem entirely. Food sources with the highest B12 content, beef liver, clams, oysters, and sardines, provide the most concentrated dietary supply. Vincent was 70 years old and had been dealing with persistent foot tingling for 3 years. 2 neurologists had attributed it to early diabetic neuropathy. Though his blood sugar was only mildly elevated and his HbA1c was in the pre-diabetic rather than diabetic range, he was taking omeprazole daily for reflux. A nutritional medicine practitioner tested his B12 and magnesium levels and found both in the deficient range. His serum B12 was 189 pbg/ml, below the 300 pg/ml threshold, increasingly recognized as functionally insufficient for neurological health. After switching to sublingual methylcobalamin B12 at 1,000 micrograms daily and adding pumpkin seeds, dark leafy greens, and beef liver to his diet twice a week, his tingling had decreased by roughly half within 10 weeks. His neurologist was surprised. His nutritionist was not. If this is opening your eyes to something your doctor hasn't mentioned, write in the comments, "My nerves deserve better nutrition." Leave a like so this content reaches people who need it, and subscribe so you catch the next video. Magnesium is the second major nutritional factor in peripheral nerve health, and it operates through a mechanism entirely distinct from the B vitamins. Magnesium regulates the excitability of nerve cell membranes by controlling the flow of ions through voltage-gated channels. In a magnesium-sufficient state, nerve fibers require a meaningful threshold stimulus to fire. In magnesium deficiency, this threshold drops, and nerve fibers become hyperexcitable, firing spontaneously or in response to stimuli that would not normally trigger them. This hyperexcitability manifests as the burning, tingling, and shooting pains of neuropathy, as well as the muscle cramps and restless legs that so commonly accompany peripheral neuropathy symptoms at night. Magnesium deficiency is extraordinarily common in adults over 65. The reasons are multiple. Reduced dietary intake from the shift toward processed foods, reduced absorption due to age-related intestinal changes, and increased magnesium excretion associated with insulin resistance and the use of diuretics, which are themselves commonly prescribed for the hypertension and heart conditions prevalent in this age group. The richest food sources of magnesium, dark chocolate, pumpkin seeds, almonds, cashews, and dark leafy greens like spinach and Swiss chard, are not the foods that typically feature in the daily diet of most older adults. Pumpkin seeds deserve specific emphasis because their magnesium content per gram is among the highest of any whole food, and they also provide zinc, a cofactor required for nerve repair and neurotransmitter synthesis. A small handful of pumpkin seeds daily, roughly 30 grams, provides approximately 150 milligrams of magnesium, about 35% of the daily requirement, alongside 3 grams of protein and meaningful zinc. This is an intervention that costs pennies per serving and requires no preparation. The alpha-lipoic acid story is one more layer of the nutritional neuropathy picture that the 2026 framework supports indirectly through its emphasis on whole food sources of antioxidants. Alpha-lipoic acid is both a fat-soluble and water-soluble antioxidant that reduces the oxidative damage to nerve fibers that contributes to neuropathic degeneration. It is found in small amounts in red meat, spinach, and broccoli. Clinical trials using supplemental alpha-lipoic acid at 600 milligrams per day have shown consistent benefit for diabetic neuropathy symptoms, and the same mechanism applies to nutritional neuropathy. While the food sources alone do not provide therapeutic doses, including red meat and leafy greens in the diet supports a baseline of alpha-lipoic acid intake that the previous low-fat dietary guidelines had effectively reduced. The medication connection is one of the most important things this video can communicate because it explains why so many older adults develop worsening neuropathy despite taking their prescribed medications and eating reasonably well. The drug nutrient depletion problem is widely recognized in nutritional medicine, but almost never discussed in standard clinical encounters, because the conversation requires time that most appointments do not allow. Several of the most commonly prescribed medications in older adults directly deplete the nutrients that peripheral nerves depend on. Metformin, one of the most widely used diabetes medications, reduces B12 absorption and has been associated with worsening neuropathy in long-term users, a particularly cruel irony given that metformin is prescribed for the condition that causes diabetic neuropathy in the first place. Proton pump inhibitors like omeprazole and pantoprazole reduce B12 and magnesium absorption by impairing the gastric acid environment required for their release from food. Thiazide diuretics deplete magnesium through increased urinary excretion. Loop diuretics, used for heart failure and hypertension, deplete both magnesium and thiamine. Statins, while not directly depleting B vitamins, reduce CoQ10, a compound required for mitochondrial energy production in nerve cells, potentially contributing to the peripheral neuropathy that some statin users develop. None of this information is intended to suggest that people should stop their medications. These drugs have genuine indications and benefits. The point is that older adults on multiple long-term medications have an above-average nutritional vulnerability that requires above-average nutritional attention. Meeting the 2026 Dietary Framework's recommendations for nutrient-dense whole foods becomes more important, not less, when medications are creating additional nutritional demands. The difference between subclinical deficiency and frank deficiency is important for understanding why so many older adults have unrecognized nutritional neuropathy. Standard blood tests for B12 often use a reference range of 200 to 900 ppm annual, with anything above 200 reported as normal. But neurological symptoms of B12 deficiency frequently appear at levels between 200 and 400 pg/ml, particularly in older adults whose neurological tissue is already more vulnerable. An older adult with a B12 of 220 pg/ml will be told their B12 is normal, given no intervention, and watched as their neuropathy slowly worsens over years. Functional B12 testing, using methylmalonic acid and homocysteine as biomarkers, identifies B12 insufficiency at the cellular level rather than by blood level alone, and is a more accurate screen for B12-related neuropathy. This is not the standard of care in most clinical settings, but it is worth requesting from a physician or nutritional medicine practitioner if neuropathy symptoms are present and standard B12 levels appear borderline. The balance and fall risk dimension of peripheral neuropathy deserves explicit mention because it is the consequence that most profoundly affects independence and quality of life. Peripheral nerves do not only carry pain and temperature signals, they carry proprioceptive signals, the continuous sensory feedback from joints and muscles that tells the brain where the body is in space. When these fibers are damaged by nutritional neuropathy, proprioception is impaired. The affected person cannot accurately sense the position of their feet and ankles. They compensate with increased reliance on visual feedback, which is sufficient in well-lit environments but fails in darkness, on uneven surfaces, and in the bathroom at night. This is why peripheral neuropathy is one of the most significant independent risk factors for falls in older adults, and why a dietary intervention that partially reverses it is a meaningful fall prevention strategy, not just a symptom management measure. The practical fall prevention argument for addressing nutritional neuropathy through diet is therefore not a minor comfort measure. It is a safety intervention with consequences for independence, hospitalization rates, and mortality. The 2026 Dietary Framework's emphasis on nutritional adequacy in older adults has a direct physical safety component that rarely features in public health messaging about diet, but that is entirely consistent with the evidence. Eat the liver, add the pumpkin seeds, include the fatty fish. Your nervous system is waiting for the materials it needs to repair itself. And unlike most medical conditions affecting older adults, this one can actually be addressed at the grocery store. The gut-nerve axis is an emerging dimension of peripheral neuropathy that the 2026 guidelines indirectly support through their emphasis on fermented foods and dietary fiber. The gut microbiome plays a role in B vitamin synthesis, particularly B12, folate, and biotin, and in the production of short-chain fatty acids that support the integrity of the intestinal lining through which nutrients are absorbed. A dysbiotic gut microbiome, one with reduced bacterial diversity and increased populations of inflammatory species, impairs both local B vitamin synthesis and the absorption of dietary B vitamins across the intestinal wall. Chronic antibiotic use, highly prevalent in older adults, is one of the most significant causes of gut dysbiosis and is therefore an indirect cause of the B vitamin insufficiency that drives neuropathy. The dietary correction for this includes at least one daily serving of a fermented food, plain full-fat yogurt kefir, or aged cheese, alongside a diverse fiber intake from vegetables, legumes, and whole fruit that feeds and sustains a healthy bacterial population. The connection between dietary fat quality and nerve health is one more mechanism that the old guidelines inadvertently damaged by recommending the replacement of saturated fats with polyunsaturated vegetable oils. Myelin is approximately 70% lipid by weight, and its composition reflects the fatty acid profile of the diet. A myelin sheath built predominantly from stable saturated and monounsaturated fatty acids maintains its structural integrity under oxidative stress. A myelin sheath with high concentrations of omega-6 polyunsaturated fatty acids from decades of seed oil consumption is structurally more vulnerable to the oxidative damage that accelerates demyelination. This is a slow process accumulating over decades, and it is reversible only slowly, but the dietary shift toward animal fats, butter, tallow, and full-fat dairy that the 2026 framework supports has neurological benefits that extend beyond the cardiovascular discussion in which the fat rehabilitation debate is usually framed. The patient who recovers from nutritional neuropathy does not always have a dramatic story. The changes are usually gradual: less burning at night, fewer episodes of sharp shooting pain, a sensation of the feet feeling more present and connected to the floor. Proprioception improves quietly, and the person notices only retrospectively that they are more confident on stairs, less frightened of uneven pavements, less anxious in dim light. The recovery from severe long-standing neuropathy is incomplete in most cases, because some nerve fiber damage is permanent. But partial recovery is consistent and meaningful, and preventing further deterioration while allowing maximum natural regeneration is entirely achievable through the nutritional approach described in this video. The investment required is small: beef liver twice a week, sardines or mackerel twice a week, eggs daily, pumpkin seeds and almonds as snacks, dark leafy greens at least once a day, plain full-fat yogurt for gut support. These are ordinary foods. They are available everywhere. They cost less combined than a single month of a typical B-complex supplement, and they deliver their nutrients in a matrix of cofactors, structural lipids, and trace minerals that the supplement aisle cannot replicate. The 2026 guidelines said, explicitly, that real food beats isolated supplements for nutritional outcomes in older adults. This is what that principle looks like in practice. The autonomic neuropathy dimension is worth briefly addressing because it is less commonly associated with nutritional deficiency in popular understanding, but is meaningfully relevant to older adults. Autonomic nerves, those controlling involuntary functions like heart rate, blood pressure regulation, digestion, and bladder control, are also subject to nutritional neuropathy. B12 deficiency autonomic neuropathy can manifest as orthostatic hypotension, the dizziness and lightheadedness that occurs when standing up, which is itself a significant fall risk factor. It can manifest as impaired bowel motility, constipation, and disordered gastric emptying. It can contribute to the urinary frequency and incontinence that many older adults accept as unavoidable consequences of aging. The same nutritional correction that addresses peripheral sensory neuropathy also addresses autonomic nerve health through the same myelin maintenance and nerve repair mechanisms. People who begin the dietary protocol described in this video sometimes report improvements in digestive regularity, less dizziness on standing, and better bladder control alongside the expected improvements in foot sensation, without having made any connection between these improvements and nerve health. They are connected. The sleep disruption caused by neuropathic symptoms is another consequence that the dietary intervention addresses. The burning and tingling that worsen at rest and at night are among the most reported reasons that older adults with peripheral neuropathy have poor sleep. The relationship between sleep deprivation and nerve repair capacity is bidirectional. Poor sleep impairs the growth hormone secretion and cellular repair processes that nerve tissue relies on for recovery, and neuropathic pain disrupts sleep. Reducing neuropathic symptom severity through nutritional repair therefore has a downstream effect on sleep quality, which in turn accelerates the repair process. This positive feedback loop, often overlooked in clinical discussions of neuropathy management, is one of the reasons that consistent nutritional intervention produces improvements that compound over time rather than plateauing after an initial improvement. The practical nutritional protocol for adults with tingling, burning, or numbness in the feet and legs builds on these mechanisms directly. Include beef liver once or twice a week for B12, folate, and riboflavin. Add eggs daily for choline and additional B12 in a highly bioavailable form. Eat pumpkin seeds and almonds as regular snacks for magnesium and zinc. The timeline for improvement in nutritional neuropathy is longer than for most dietary interventions because nerve repair is slow. Myelin regeneration occurs over weeks to months. not days. Most people who implement the full nutritional protocol consistently report a reduction in symptom intensity within 8 to 12 weeks, with continued gradual improvement over 6 months. This is not as fast as some would hope, but it is substantially faster than the progression of untreated nutritional neuropathy, which worsens steadily as deficiencies deepen. For any older adult watching this video who has been told that the tingling in their feet is just something they have to live with, the answer from the 2026 guidelines and the research that informs them is, not necessarily. The nervous system has repair capacity. That capacity requires nutritional substrate. The substrate is available in ordinary food. The question is only whether it is consistently being provided. Your feet deserve to feel the floor properly. Your nerves deserve the materials they need. Both are available, starting with your next grocery shop. Thank you for staying until the end. Drop a like and a comment telling me if any of this matched your experience. It helps me make the next video better. And if you want to support this channel, the Buy Me a Coffee link is in the description. Take care, and we will see you in the next video.